All right, so so now we're doing, I am scheduled to do a case presentation. So I thought I would show some lesions related to what we just talked about. You know, I mean, I think they're mostly straightforward examples of what we're talking about. So hopefully, you know, you can just relax and enjoy. So I'm beginning with obviously an example of a tubular carcinoma. This is a 52-year-old with image detected microcalcifications. And we have, you can see a small glandular proliferation infiltrating through these core needle biopsies. Oh, wait. Hang on a second. Spoiler. All right. This is my session. I have them in the wrong order. As soon as I said the word small glandular proliferation. Okay, so this is a 52-year-old with image detected microcalcifications. You travel with these. And it's just a very nice illustration of a columnar cell lesion, right? You can see, well, first of all, you see the calcifications. You see the calcifications here and the variable dilatation of the acini of the terminal duct lobular units. And so this kind of appearance, I mean, some of them you'd categorize, I think, just as microcysts, but when you have multiple like this within the terminal duct lobular unit, and then, as I say, I make my sort of primary impression about whether it's flat epithelial atypia or not on low power. And really, it didn't look like FEA to me. It wasn't monomorphic. And then also the irregular contour of the spaces favors it being columnar cell change or columnar cell hyperplasia. And so you can see we've got columnar epithelial cells there. Oops, sorry, let me get the condenser. They are lining the spaces. There are a few little snouts, maybe not, you know, a few little snouts here. And so this is just a, you know, a sort of an easy example of columnar cell change and perhaps some columnar cell hyperplasia with the associated calcifications. So, you know, this would be the sort of case you'd always look around carefully to see if there's any lobular neoplasia of any sort, tubular carcinoma, that would be so just an easy starting lesion, columnar cell change. And please feel free if you have questions as we go. All right, so now we move to our atypical, and you can see what I mean already on low power. Doesn't it look atypical? Sorry, it's a bit of a folded slide. But even these rounded spaces, they look round and rigid, and the cytology of the cells looks monomorphic on low power. And so to my eye, this is immediately an example of flat epithelial atypia. And to Eddie's point that was asked earlier, you know, you can see that there are just a little tiny focus here of cribber forming. So if this was all we had on a core needle biopsy, you know, we would call it atypical ductal hyperplasia in association with arising in association with flat epithelial atypia. So on high power, you can see again the sort of rounded spaces, the rigidity of those rounded spaces, and the monomorphic cytology of the epithelial cells. So I need to maybe brighten it a little bit for you. Oops. We do have little micropapillations. So again, another feature of an atypical ductal proliferation. And then as you saw as well as I was cruising around, there is actually more than just FEA going on in this case. We have areas of really, you know, frankly, atypical ductal hyperplasia, and you might even have areas that you could call low-grade DCIS in this example. atypia in this epithelial population here. So really, for this case, I just wanted to kind of emphasize the point of the low power diagnosis of flat epithelial atypia. Yeah. I didn't want to steal Eddie's thunder, but yes, we can do that. So here, I think it's more usual ductal hyperplasia in this proliferation. There's variability of the epithelial cells. You've got intranuclear inclusions in some areas and slit-like spaces. So I think this is just usual ductal hyperplasia in this particular papillary lesion. Hopefully you agree. Yeah, yeah, it's very striking, I think. I agree with you. So this one is patient with a 4 millimeter breast mass and some calcifications. So here we have our little breast mass, which of course is just a little fibroadenoma. But then another area again where it's flat epithelial atypia. I think here you might wonder if it's just some sort of apocrine proliferation because it is a little pinker, but the spaces are very rigid. And when you look on high power, it is quite monotonous. The epithelial population is quite monotonous. And then you do have a bridge going across here, which is quite rigid. So I think one of the things about FEA is, you know, mostly in the picture books, we mostly think of it as being quite a hyperchromatic, more, you know, a bluish proliferation, but sometimes you know, depending on the staining, I think it can look quite pink. So ruling out an apocrine entity, you know, you'd want to make sure there's no granules. You'd look at the NC ratio. Obviously here we've got frank atypical ductal hyperplasia. Now we've got good rigid bridges and spaces, but still some flat epithelial atypia as well. So this is a core needle biopsy. So this is one that I would just call atypical ductal hyperplasia. I would not go to low-grade DCIS. I guess I'd be curious, would other people go to low-grade DCIS in this? No, good, all right. So this is a young woman, 30, what is it? The slide is 36, the female is 58 with a breast mass and calcifications. So now, you know, now we've got a much more extensive area, right? It's still, oh no, this is an excision now. So we've got a much more extensive area of involvement. And so no question that we're dealing with carcinoma in situ, right? So it's extensively involving many spaces, really nice round cribriform. And this is such, I love polarization. Makes, you know, I think it's so neat and tidy. I like when you find it and it's doing its thing so beautifully as in this example here. So the epithelial cells are really nicely polarized. It's low cytologic atypia in most of the spaces. And I think, you know, one of the other features of low-grade lesions is you can get this sort of, I don't know whether I'll be able to illustrate it so nicely here, but you get kind of this mosaic pattern of the epithelial cells. You can see the cell borders very nicely. Actually, you can see it, I think, in this one. Show it on the screen so well, but you see how you can sort of see the cell membranes between the cells. It's that higher power. Here, it sort of gives you like this mosaic pattern around all the low-grade nuclei, which I think can be a helpful feature for deciding about atypia versus non-atypical lesions. Oh, actually, this had a curious little thing here. So this one, um, how about these areas here? What do people think about this stuff? Yeah, yeah. So, and a little bit of a mimic for DCIS, but you've got DCIS over here, and then suddenly, I don't know, kind of separated from that, you've got this sort of scattershot appearance of these solid rounded nests that, you know, I feel could be misinterpreted as DCIS, but I agree with you. The pattern is that of lymphovascular space invasion. Do you see how you know, I was mentioning having normal terminal duct lobular units kind of in between, and a little bit of retraction artifact around some of the spaces. So certainly something to think about. And, you know, if you have areas of classic LVI, that could help. But I think there was, you know, there was invasion on another slide. I don't think this particular slide has it.
We have seen several cases which are massive, really massive. Is that something?
Yeah, so that's, yeah, so that's a good question. So the question was about sort of this type of pattern of invasion of rounded nests invading that can look like DCIS, and frankly, maybe some of that was, but yeah, so I think, you know, I'm not sure about the biological sort of underpinnings of that and what's going on there, but it's certainly a recognized pattern. And you sometimes see that in lymph nodes, right? Where it looks like these big, big rounded nests that look like DCIS in lymph nodes, but it's that pattern of invasion where the myoepithelial cells are lost around the entire rounded nest. And I think, you know, you can sometimes appreciate sort of a growth, an infiltrative growth pattern, even though it's not like fingers of growth. But the way the rounded nests are distributed, it looks invasive. Sort of what you would see with solid papillary carcinoma, I think, in some ways, where it looks invasive, even though the nests are still rounded. It's got that infiltrative growth pattern. Yeah. But definitely it's a potential pitfall. And you'll even have what look like the myoepithelial cells around the nests. We did start a study once looking at that, but, you know, too few cases really to make any impact. Yeah. 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 Yeah, I mean, maybe you know, we could do something more sophisticated than we were trying to do 20 years ago. But yeah, that we had a couple of index cases where it looked like a myoepithelial cell layer, but it was really very compressed epithelial cells. So, you know, you have kind of this mimicry of compounded, the mimicry of DCIS is compounded by those attenuated epithelial cells. All right. And so this is just, you know, another pattern of DCIS where it's very extensive. It's retract, you know, I think it's not as well fixed as one would like. There's a lot of retraction around the spaces, but it has some apocrine features. And so that kind of, you know, you can have DCIS with apocrine features. As I said, that can be ER negative. Obviously wouldn't really be a challenge in diagnosis because you've got really high grade nuclei. They're not going to be, you're not going to mistake this for any sort of benign proliferation. I think one of the things, and maybe Eddie has some cases in her collection, when when you have very apocrine lesions where it's falling apart, I think you should think about pleomorphic apocrine LCIS. Here, we have areas where it's trying to polarize, you know, where the cells are sticking together a little bit. And you can see that, you know, there is some cribriform pattern here, even though most of them are falling apart. And I think other areas where there's, you know, better evidence that it's a ductal proliferation rather than a lobular, you know, where it's striving to have architecture. But I think, you know, this would be one of those cases where you'd be wondering about pleomorphic LCIS versus DCIS.
How much do you rely on immunostinctions?
So we use immunostains for in situ carcinomas where we're struggling to differentiate DCIS from LCIS. I would say that if I have architecture, so in solid proliferations where I have that differential diagnosis, if I can see areas of polarization or like microacina formation, so if morphologically on H&E I have architectural features that point me in the direction of DCIS and that I'm confident about, then generally I don't use the markers in that situation. I find the times where I struggle the most are where it's a solid proliferation. And I just can't tell, maybe I'm feeling less confident now, or maybe we just see more of these non-classic variants of LCIS. And those would be the situations where we would do E-cadherin and P120 catenin. And, that if we have an absence of expression or reduced expression with E-cadherin and cytoplasmic expression with P120 catenin, then that would support a diagnosis of LCIS, and then membranous pattern would support the diagnosis of DCIS. But if I have good architecture that I'm confident in, then I lean towards DCIS and I don't do the stains. Yeah, so atypical apocrine proliferations versus, I don't use the diagnosis of atypical apocrine hyperplasia. I guess maybe you could say ADH with some apocrine features or something like that. I would rely on sort of extent and qualitatively. Apocrine lesions are really hard actually, because you need that sort of three to fourfold variation in nucleus size to get to atypical. So I again sort of rely on architecture. If there's very good for the lower end of the spectrum, lower grade lesions, because in high grade lesions, it's easy, right? You can make a diagnosis of DCIS. But for low grade lesions, you still want to see nucleus size variability, but they're still going to be kind of round and regular, I guess. I look for architecture. Is there really good going cribriforming that I'm sure is atypical? I'd want it to be somewhat extensive. And if it was just limited in extent, I guess I'd probably be descriptive. In the setting of core needle biopsy, you'd probably want an excision. I think the other time I struggle is with atypical apocrine adenosis. And when is it just atypical apocrine adenosis versus atypical apocrine DCIS, versus apocrine DCIS involving adenosis. And again, then I would look around the rest of the specimen to see if there are other areas that I can call DCIS. Is there DCIS elsewhere that looks similar to what's involving the adenosis? That's sort of my management approach there. Okay, so. All right, this case, it might be a little, let's see, I think this is the one that I had the picture of in the talk. So yeah, this is the case that was called invasive carcinoma. And, I think I think I have two profiles. Here's a better profile. Okay, so, I think the thing is, as I was saying in the presentation, it's got an irregular shape to the nests. And so I think naturally you do think of some sort of infiltrative process. But I think, as I was trying to point out, if you've got hyalinization of the stroma, and maybe that it's not so easy to see on the screen, but if you have sort of hyalinization of the stroma, I always try to sort of think about the possibility of a benign sclerosing lesion first, because, you don't want to have somebody over-treated or treated unnecessarily. Of course, you can make the argument the other way. You don't want to miss invasive carcinoma either, but I think starting that way and then going from there. And honestly, if you keep an open mind, and then you'll not sort of anchor on the diagnosis of invasion, and you'll not overlook, you know, the myoepithelial cells, which I believe are there. And, you know, the basement membrane too, I think, is sort of outlining the nest. Now, basement membrane, you can have in invasive carcinomas, but I believe that these are myoepithelial cells. And I think this profile does have, let me see if I can find the necrosis. And you know, also it points to these slit-like spaces. There are nuclei that are smaller and darker and oval that are running parallel to the spaces. There are larger nuclei with clear sort of chromatin. So in usual ductal hyperplasia, there's a lot of variability in how one nucleus looks to another, not just in size and shape, which you'll get in intermediate grade DCIS, but in actual how the chromatin looks, I think. And that's that's the feature I use a lot to help me make the distinction from UDH and DCIS. I'm trying to find the necrosis to sort of see if it may not be on this profile as well. That's the picture. But anyway, so this is UDH in a sclerosing lesion. Okay, so this 61-year-old with pleomorphic calcifications. Oh no, not a 61-year-old. I made up a wrong history. Sorry. Yeah, this is a younger patient. Right, so look at this. So, you know, round rigid spaces, I guess, but tons of necrosis and really high, you know, even on this low power, you can see that there's a lot of variability in the nuclei. They look like high grade nuclei. And this is just an unusual example of really extensive clinging carcinoma in a young patient. In areas, there were some more kind of almost micropapillary formations. Here you can see it's getting to be sort of, you know, other types of DCIS, so micropapillary pattern DCIS as well. But just a nice illustration of clinging carcinoma, which, you know, I don't think we see that commonly, honestly. So this one is just to sort of contrast with DCIS, high nuclear grade. And you can see on low powers, I'm scanning around, it looks more like a disheesive population. So on low power, you'd be thinking of LCIS, I think. And then just going on higher power, you can see that it is quite disheesive. Sorry, let me get the condenser. And I don't see, so even with disheesive populations, I still try and look, if it's a solid proliferation, try to look and see if there's any features that would point me in the direction of a ductal proliferation. I really don't see any evidence of any architecture. And we just scrolled by some intracytoplasmic, some very nice intracytoplasmic inclusions. Again, another feature that would favor this being of a lobular phenotype. So we have no obvious architectural atypia in the form of polarization, cribriforming bridges or arcades. We have a disheesive population. We have intracytoplasmic vacuoles. You know, nuclear atypia, I think there's some considerable variability in nuclear size and shape here. Maybe more of them are kind of type B nuclei. So, you know, LCIS is, and Eddie's going to talk more about this, you know, has nuclear degrees of nuclear atypia. But if you start to see sort of significant populations of cells with a lot of nuclear pleomorphism, then that would really push you into a pleomorphic LCIS rather than just classic LCIS. And I think maybe this other area was a little bit more atypical. Let me just see. And often in these pleomorphic LCISs, there are areas of classic LCIS as well. And I know you'll have more examples of this tomorrow, but just to sort of show you some, you know, something that's in the differential diagnosis with high-grade DCIS. Pleomorphic LCIS, this one, yeah. So pleomorphic LCIS on core biopsy, they would get an excision. So they'd certainly have an excision. And then for how the patient is managed beyond the excision. So you know, it's not well defined, I would say. And even within our institution, I think the oncologists the radiation oncologists manage differently. The surgeons would try to get clear margins in the same way that we do. We sort of extrapolate from DCIS. So by default, they're using a 2 millimeter if it's pure pleomorphic LCIS. And then, you know, some of our radiation oncologists want to radiate those patients and others, you know, no. So I don't know what's the memorial. Yeah, save it for tomorrow. Yeah. All right, let's see. What did I have here? That's my only area. All right, so here is my sort of, you know, intermediate grade DCIS versus UDH challenge. And these are the ones that I think can be so difficult. I don't know, this is my biggest struggle. Is it you, or you think it's easy? and as I was trying to sort of mention previously, I use how the new. So first, I think the differential here is UDH versus intermediate grade DCIS. You've got an epithelial proliferation. You know, maybe some of you think this is an obvious example of DCIS, and you know, I think it is DCIS, but I don't think it's necessarily an obvious example of DCIS. There's some variability in the nuclei. So, you know, and it's not massively involving the tissue. So, you know, if something limited, I might think about usual ductal hyperplasia in that setting. But, you know, as you start to look at it, I think the nuclei, while they vary a little bit in size and shape, they do have a similar quality one to another. It's not perfect, of course, because you're going to have some dark nuclei. There is a mitotic figure, so that would lean me towards DCIS versus UDH, but that's not to say that you can't have mitoses in UDH. This is the sort of thing I mean by an architectural pattern, right? It's not a cribriform space as such, but it's trying to kind of form a little rosette or something. So even though it's intermediate grade DCIS, it's trying to form structure. And so those are things that I look for in my distinction of UDH versus intermediate grade DCIS. And then there's a more obvious area up here where I think you could more easily decide about it being DCIS. I think it's sort of got a little bit of a pagetoid growth here, actually. It looks like it's growing under the normal ductal epithelium. And, you know, we always think of lobular lesions as being pagetoid, but DCIS can also have a pagetoid growth pattern. So this is just one of those difficult cases. And you know, as you start to look, I think, you know, there is some significant nuclear atypia. Oops, let me get it more on the screen. These are some pretty big nuclei here. So, you know, I think once you make that sort of decision and, you know, decide that I think once you go on high power and you can see it, you're like well on the track of DCIS. But I think on scanning magnification, this is one of those that I think could look like UDH on low power. The inflammatory cells, another kind of soft clue that it might be something other than just UDH. I don't think it's very common to see inflammation around UDH. So if I see that, that might be another clue that I'm dealing with something more. This one is. Oh yeah, so here's another one of these tricky things where you've got, you know, you've got a lot going on, right? So this is a, say, 48-year-old woman with a nodule, a 9mm nodule. And so there's a lot of proliferation, there's a lot of stromal change, there's a lot of, you know, I don't know, irregular contours to some of the nests. And so I think, you know, people might worry about some sort of atypical or infiltrative process, but notice that there are these kind of fibrovascular cores, or, you know, it's some sort of papillary process, I think. Notice that there is a myoepithelial cell layer, both at the edge and actually running along some of the fibrovascular cores, you can see it. And so I think having made the judgment that you've got something that's within a duct and something that seems to be papillary and that there are myoepithelial cells on the fibrovascular cores, then looking at the epithelial proliferation and making the deciding then whether it's an atypical or non-atypical proliferation. And, you know, here we have variability in nucleus size and shape, maybe a little bit of streaming. The nuclei, the cells in the middle seem smaller, or certainly have more cytoplasm. There are slit-like spaces. So with respect to the epithelial proliferation, it looks like usual ductal hyperplasia within area, you know, sort of multiple papillomas. So areas of papillomatosis with usual ductal hyperplasia. So this would probably get excised because it's a little mess and may have been symptomatic, but not necessarily, I guess, nowadays. This is a really nice area of streaming of the epithelial cells. Area of usual ductal hyperplasia. How are we doing for time? A few more cases? We've all got the energy. I can keep going. We look at cases. All right, so this is another, you know, area with a little bit of sclerosis. You can see there's a little bit of sclerosis, change in the stroma here. Maybe it's kind of radiating out. So you might have a little portion of a radial scar here. And then the epithelial proliferation, just again, you know, emphasizing challenges with usual ductal hyperplasia. I think, you know, not such a difficult case, but just showing you some more examples to illustrate usual ductal hyperplasia. Spaces, slit-like spaces, variability in nucleus size and shape, some clearing of some of the nuclei. So some clearing of the nuclei. Again, variability in how hyperchromatic the nuclei from one to another. No polarization around these spaces here. So just a little bit of usual ductal hyperplasia, probably a portion of a radial scar here. And here you can see this change in the stroma. So not to mistake this for a focus of invasive carcinoma, even though it's small, round little glands. They're the glands that are entrapped in the center of the sclerotic core of the radial scar. And you can see, slide's a little bit pale, but you can see the myoepithelial cell layer around some of these glands. It becomes, frankly, it becomes more attenuated around the ones right in the middle. So that can be challenging. And I'll talk a little bit more about that in my benign or my small glandular proliferation talk slide seminar. So. See this one. All right, so here we have an example of what looks like DCIS, right? There's a lot of epithelial proliferation involving many ducts and lobules. There's involvement of lobules. So we talked a little bit about how involvement of lobules can be a mimic for microinvasion. So certainly things like this can look like areas of microinvasion. You want to look for myoepithelial cells around the acini to help you make that determination. And it looks like there are some there, they're very attenuated. But you do wonder whether some of these foci might be cells just directly in the stroma. And this case did in fact have areas of microinvasion and all, like here, for example, where it doesn't look like they're within an acinus, these tumor cells here. So this is microinvasion. And there were multiple foci within this case. So you can see that here. You're looking at epithelial cells that in irregular nests or even singly look very, very malignant looking. So cases like this, you can do, I mean, I think one can be confident about the microinvasion in this case. But you could do myoepithelial cell markers if you felt unsure. Might be useful to do a keratin stain as well. You would see very nicely just how much invasion there is. If you have a combination of a keratin and P63, that's brilliant. HER2 is likely to also very nicely highlight the microinvasion. So when you're doing your ER, PR, and HER2 stains, always good to check to make sure no microinvasion has shown up on the deeper levels. Don't just, you know, say, oh yes, it's positive in the DC. Well, I guess if you're doing DCIS, you wouldn't have HER2, right? Getting ahead of myself. But if you had HER2, you might see more microinvasion than you'd originally thought, or there might be a larger area that meets criteria for invasion rather than just microinvasion.
But there is a lot of it, almost like in every TDLU, there is a focus of microinvasion.
Yeah.
Is this microinvasion or is this an invasive carcinoma? How do I approach that? I don't know, because I struggle with these cases too.
Yeah, no, it's an excellent question. And you feel like the bulk, I mean, there's sufficient bulk of disease that it is beyond just a, you know, T1MI, right? So I think I still, if nothing is greater than a millimeter, even though it's multifocal in this way, I would still call it microinvasion, but I would just like say that it's present, you know, widely throughout the specimen and convey that. I know our medical oncologists get very nervous about cases like this, and they probably would get chemotherapy, even though it's microinvasive disease. Would that be how it's handled in your institution?
Yeah, it's almost
That's a good approach, right? Yeah. 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 Yeah, no, I know that if they're like this, where there's multiple foci of microinvasion, our sort of head oncologist, breast oncologist would treat for sure. Just another example of DCIS. Yeah, this is actually a nice example. So this is extensive DCIS, right? And then there's DCIS involving a sclerosing lesion here, which, you know, it starts to be these sort of small glands, very sclerotic stroma. And I think one can, in this situation, definitely worry about invasion in this area. So this would be the sort of space where you would want to do myoepithelial cell markers. It's also right beside the biopsy site, and I'll talk a little bit more about this later. But in the setting of a biopsy site, you'd want to be very careful about diagnosing invasive carcinoma without a conventional pattern of invasion. But you can see that there is an underlying complex sclerosing lesion here. You've got this fibroelastotic stroma. You've got these entrapped glands that really look like, you know, the center of a complex sclerosing lesion. So when they're involved by DCIS, as in areas of this case, it can be really challenging to decide how to manage them. And I think myoepithelial cell markers become critical in cases like that. Now, in the biopsy site, myoepithelial cell markers aren't always going to help you. And as I say, I'll talk about that issue later on. But this is an example of DCIS where there is involvement of, you know, there's a background complex sclerosing lesion in this case that makes it ever so difficult to, you know, be confident about invasive carcinoma without the use of myoepithelial cell markers. Yeah, yeah. Yeah, but I mean, I hope you agree that it looks like at least that there's some underlying complex sclerosing lesion here. So, okay. Okay, here's another example of a complex sclerosing lesion. So we have here, or, you know, complex sclerosing lesion, there's sclerosis, maybe a fibrovascular core, a little bit of papillary stuff going on, and areas of necrosis. So this is the necrosis we were talking about earlier. And so, you know, it looks a little different than the necrosis you have in DCIS. Not perfectly different. I think you could certainly have this necrosis in DCIS, but there's some sort of difference in the quality that is a little bit striking to me. But then if you look at the epithelial proliferation, I think it looks like usual ductal hyperplasia, right? You've got irregular slit-like spaces. There seems to be a preference for those spaces at the periphery. Fairly low NC ratio in this portion of the epithelial proliferation. Heterogeneity in how they look. But, you know, people might be, there's no polarization of the epithelial cells around these spaces, I don't think. But I could see how people might be concerned because of the necrosis. And so myoepithelial, CK5-6 and ER were done in this case. And so here is the CK5-6, and you can see that it is nicely heterogeneous. Here's that area that was the necrosis. So it shows the pattern of expression that you would expect for usual ductal hyperplasia. And then the ER shows variable expression. So this is the pattern that you expect in usual ductal hyperplasia, where there are strong nuclei, weak nuclei, negative nuclei, and that's exactly what you would expect. And actually over here is an area that's more like columnar cell change. And you know how I said that it's not useful, ER and CK56 are not useful in columnar cell change because it shows strong diffuse expression, even in the non-atypical lesions. So we wouldn't use it in that setting. But here, the ER is of great value in helping us realize that this is a non-atypical lesion, which I think it looked like on H&E. But you know, if you needed the reassurance, and we all sometimes need a little reassurance, it's very helpful in that setting. So maybe should we stop there?
Thank you very much.